Hawkridge and Umesh have outlined some of the core concepts and recent developments in the public mental health system, both globally and in South Africa. We'd now like to bring the discussion even closer to home and into this room. What are our own experiences of the public mental health work? As a confederation of diverse healthcare providers, the SAPC can be seen to be a microcosm of the national healthcare system. In the same way, we have a broad range of practitioners here today, and we would now like to pool our knowledge by sharing the experience we have here between us. This is where the idea of having an SAPC dialogue comes in. We can make use of our rich diversity in our confederation by creating opportunities like this for us to share our knowledge and to see how this can take us forward. I'm going to ask Sue Hawkridge to start off our discussion. Sue is a registered child and adolescent psychiatrist. She's a fellow of the South African College of Psychiatrists. She's also a senior lecturer in the Department of Psychiatry at Stellenbosch University and a visiting lecturer in the Department of Psychology at Rhodes University and the University of the Western Cape. Her current research area is early onset psychotic disorders, whilst other areas of interest include pediatric psychopharmacology, pediatric neuropsychiatry, child and adolescent forensic psychiatry, and community-based child psychotherapy. And to quote her just now, she says, if we want to be part of this system, we need to know what the system looks like. Over to you.
Thanks very much for the introduction, and also for inviting me to speak to you. The first thing I have to make very clear is that I'm not here as a representative of the Department of Health. I'm carrying no official mandate. All I carry is 30 years experience in the trenches. This title was a bit aspirational, as you'll see. I just want to show you what the structure is at the moment and is likely to be for the foreseeable future, and how things are layered and how things work, because even the people who work within the system don't necessarily know all of the system, and you have to have a map in order to be able to work out where you're starting from, if that's where you want to start from. So we have 3 layers of healthcare. There's primary healthcare, which consists of community health centres or day hospitals or clinics or local clinics or whatever one wants to call them, and district hospitals. Those are also regarded as primary healthcare. That turned out to be mostly theoretical, because in fact most of them offer some specialist services, and primary healthcare by definition does not have specialist services, only generalist services. The layer of specialist care is found in community psychiatry clinics, which are also held at local level, but they're actually part of the second layer of care, and in psychiatric and regional hospitals. Now that is generalized, specialized psychiatric or mental health care. So clinical psychologists, we count educational psychologists, despite the current controversies, pediatricians, neurologists, psychiatrists, and clinical psychologists, of course. The tertiary care layer is found in the central hospitals and in specialized psychiatry units, sometimes outside that, but also sometimes in consultatory clinics in the periphery, what we call anything outside the ivory tower. And just to remind you, now Crick's already had a map up of the Western Cape. These are our districts: Central Karoo, Eden, Winelands, Overberg, West Coast, all the way up to there, and Metro. And that there Metro is divided into 4 substructures. Northern and Tygerberg sit together. Khayelitsha and Eastern sit together. West, I've forgotten what that's called. Southern. The Southern and Western something or other. Yeah, Southern, but it goes all the way far to the north. That's right. It was one of the less coherent moments. Southern and Central. And there's one there called Klipfontein, which I can't quite see from there. Okay. Klipfontein is where GF used to be. And then Mitchell's Plain and Klipfontein go together, and Southern and whatever this is called now go together. They're huge extents. And the biggest population growth is in these areas here. And the population density is also quite significantly greater than average in big places like Masiphumelelo and the informal settlements around Strand and Gordons Bay, with massive incoming numbers. There are also big foci of recent settlers in the northern parts of the northern substructure. So that when the Western Cape talks about its health districts, it can be talking about rural districts, or it can be talking about what people are loosely calling a substructure, which is gosh, this thing drops off quite easily. Eh? Okay, so just an explanation about the primary care level. I mean, it always sounds so sort of, oh, it's primary care, and you're sort of thinking of a country nurse with a little bag that she carries, and something very pioneering and not particularly sophisticated. But that's not true. Primary care is kind of the health care that 97% of the population should, well, 90% of the population should get by with. If you never need anything complicated, the ordinary stuff, the arthritis, the high blood pressure, the diabetes, if you never get anything worse than that, you never need to move out of primary care. It's staffed by a family physician who's a specialist in generalized medicine, which I also enjoy as a little oxymoron, and medical officers, mental health nurses, general nurses, facility or community social workers, so very few dedicated mental health social workers, district psychologists with interns, district occupational therapists and physios, but only if you're under 6 or over 18, because this theory is that if you're between 6 and 18, you get your primary health care from the school health system, which is or has always been and remains a fairly imaginary structure. It does have some poor people working really hard, but it is simply inadequate to the task. So the point of primary care was that it's an integrated point of access. They provide emergency care, they do medical screening, and then they are supposed to be able to do a basic mental state examination and make appropriate referrals where necessary. They can manage patients with uncomplicated common conditions. That's on an inpatient or outpatient basis. They can do 72-hour in fact, they have to do 72-hour observations of patients who, because of mental illness, constitute a danger to themselves or to others, and they refuse admission. So those are certified patients, the involuntary patients. And 72 hours is the observation period that they get in which to decide whether you need to be unwillingly placed in a psychiatric environment. And they refer patients with complicated or treatment-resistant conditions to level 2. So that's what we call specialist care, and that's you guys or psychiatrists or mental health nurses, because they're also part of the specialist care. They also, at primary level, can do maintenance care of patients referred back from specialist services. And theoretically, because it's in the package of care, primary level is also supposed to take care of health education, psychosocial rehabilitation, and preventive programs. Although for all this they would need 36-hour days, let alone for 24-hour days. And just to give you a sense of what is primary care in our context, that's Karl Bremer. It's a district hospital. That is the Grassy Park Community Health Centre. That's nice and new. And that is the Woodstock CHC, which I think used to be called the Robbie Nurek, but that's an older one. Is that in town? Okay, but it's an older building, and that's right. It's been renovated and refitted and retrofitted. So some of the facilities look great, and some of them don't look so wonderful. And the ones that look worst aren't in these pictures at all, because there's no pictures of them on Google. So we'll have places like Mfuleni, where from time to time they have to do the clinic out of a container. General specialist mental health care, that's layer 2, and there's the Ntlalo Clinic, which is the neuro clinic at Stickland, and there is a young man who qualified as a psychologist, Mr. Mpunga, and drives a one-man mobile clinic around Khayelitsha providing counseling with more or less sponsorship, depending on how good the universe is feeling towards him. So that is also general specialist healthcare, mental health care. And the layer consists of community psychiatry clinics with a mental health nurse, who's pretty much the main person there, who once a week or so gets a registrar or a medical officer from one of the hospitals who provide the service. And the cover is from a district psychiatrist. Now, just quickly going back to our map there, we have one district psychiatrist for this area, one for this area, one for this area, and one for this area. 4 district psychiatrists for a metro with about 4 million people in, is it these days? So we're a bit short on the oversight layer. There are also things called large district hospitals. Somerset is a large district hospital and has specialist services. In fact, they have their own psychiatry unit and their own psychiatrist. They're talking about maybe Khayelitsha really should be a large district hospital, and if you look at their patient numbers, yes, absolutely. So that stark separation into primary and secondary level care probably was never going to work, and the edges of blurring as we speak. But most of the district hospitals will probably end up providing some sort of specialized care and should have their own clinical psychologist. So, and Khayelitsha's already got its own clinical psychologist, and so has Somerset, I think. No? Not yet. It's part of the plan. It should have. It's certainly got a psychiatrist, which is entertaining. 1 morning a week is not a psychologist. Yeah. Okay. So that was the plan. The reality is, as always, not quite there yet. The rural regional hospitals have 2 to 3 psychiatrists each, with medical officers and clinical psychologists sometimes. So there's a vacant post, I think, in the Paarl district at the moment, yeah. But theoretically, they should have a clinical psychologist in situ. And the psychiatric hospitals, of which there are 4, Valkenburg, Stikland, Lentegeur, and Alexandra counts as a psychiatric hospital, all have full multidisciplinary teams, which are, in contrast with other provinces' mental hospitals, quite relatively well staffed. So that's also level 2, although we try not to make that point too often. That's the Khayelitsha District Hospital. This is the Valkenburg, all renovated and looking lovely. And that's George, which is also a regional hospital. So the facilities for our second layer of care are large district hospitals, regional hospitals, psychiatric hospitals, and the community psychiatry clinics. And you can see that the system, as it's structured, lends itself to miscommunications and to difficulties in negotiating referral pathways, because at tertiary level our services are provincial, so that all the substructures will not be going just to their district hospital or to their psychiatric hospital, but crossing boundaries in terms of going to the tertiary hospital, which offers the service which they happen to need. So we have specialized tertiary units at Red Cross, at Hawkridge and at Tygerberg. Those would be eating disorders units, neuropsychiatry units, child and adolescent psychiatry units, and general units for treating people with complicated or treatment-resistant conditions, or very rare conditions that nobody really has much information about. And there are also specialized units at the psychiatric hospitals. So then the psychiatric hospitals aren't just level 2, they're level 2 plus level 3, and again the boundaries are blurring. Lentegeur Hospital has forensic, intellectual disability and child and adolescent subspecialist units. Stikland Hospital has got an old age psychiatry and an addiction psychiatry unit. Valkenburg's got forensic psychiatry, and Alexandra, of course, deals with intellectual disability, which is, which I would also regard as a subspecialty. That's Hawkridge, Tygerberg, Red Cross, Lentegeur, and Alex. Community-based mental health care is not an afterthought. It was part of the plan originally, the national pyramid. This is your second to bottom step of the pyramid. But in terms of implementation, it seems to have been regarded as an afterthought. So the first thing that happened when there was a change of government was they top-sliced the tertiaries and took a third of our budget, allegedly to start services within the primary health system. But of course it wasn't enough. It will never be enough. It is never going to be enough. So we ended up with quite weakened tertiary systems, but very little care in the community. And while we've actually managed to keep things going quite well in this province, that's kind of what happened at Esidimeni. And that's one of the reasons that things broke down to such an extent that 100 people died. We have avoided that here, and partly that's because we have better resources in terms of personnel. People want to work in the Western Cape. They're not wild about working in very far-flung places. And they also want to, they're okay to carry on trying to make the system work. The idealism, the enthusiasm hasn't gone away. So there's a lot of people who are still trying really hard to make this work. And when the NHI comes in, a lot of people who really believe that universal health coverage is the way to go and will be on the side of the angels, as it were. So, and that's one really important thing that we have. So there are other provinces in our country which are struggling enormously with demotivation, with burnout, with emigration, and a whole lot of issues. But in the Western Cape, we are lucky. So the whole idea of community-based mental health care was that it would be provided by community health workers. But at the moment, these guys are employed by NPOs. And very often, we get one of those saying, "Insource us," understandably. And it was originally, this whole CADO was formed to carry out home visits to patients with HIV in terms of trying to strengthen the adherence to medication and to reduce the amount of psychiatric comorbidity. And there's been a gradual role creep. Talk about role creep. These people started off as HIV counselors and home visitors, and they're gradually becoming the go-to person for any kind of mental health services which are located in the community. And we have to think very carefully about what that takes, what kind of person we're going to be looking for, and what kind of care we're going to need to take of them, because it cannot possibly be an easy task. So they've been monitoring medication in serious mental illness in 2 of our sub-districts recently. And there's extra input required there, because going into a home and talking to someone who's known to have been psychotic from time to time, who's usually taken to a mental hospital because they're aggressive, that's a different kind of thing to be having to do, rather than going into a home to look at a mummy with a new baby, or to an old person who's had a stroke and check that they're not getting bed sores. Dealing with the unknown is the scary part for the community-based workers. So we need to be looking at training, at their status and their role, and it's all currently under consideration and theoretically should include mental health. That's what all the policies say, and all the packages of care that they've carefully drawn up. So their support and supervision is not well structured at present, this cadre on the ground. And the entry criteria are not clear, and it depends on the NPO. But you can see that the work is very varied. The advantages of community-based care are essentially in the human rights field. So it's accessibility, it's fairness, it's justice. It's bringing the care to people who can't afford to get to the care. The advantage also was supposed to be integration with general medical services, and that still is the ideal. But man, it's taking a long time to get the old fossilized prejudices to move on or retire or just do something, go and work in Canada or something. But there's still people out there who say, we don't do psychiatry. And even the ones who've accepted that they will do psychiatry won't do children, so at least not with psychiatry. So it's been a real battle to try to overcome prejudices and stigma. But we keep on fighting. The thing with community-based care is that your language and cultural congruence is more likely to be a better fit. It's unlikely in the near future that we will get enough specialized mental health professionals who are fluent enough, and not just conversational, but home language fluent enough to be working with people's psychological material in their home language. Because speaking as an English first language speaker who's been working with Afrikaans as my professional language for 30 years odd now, it's not the same. It's hard, and it takes a long time to become that proficient that you can actually detect subtleties in a language that's not your mother tongue. Okay, stepped care can save tertiary services for those who really need it, because you can do 13 years of university training and you will still end up having to sort out why the battered wife doesn't go to the social worker and call the police, and why the police aren't reacting, and who needs a grant for this and that. There are other things that people at tertiary level should be doing which we don't have time to do, because a lot of our time is taken up with things that other people could be doing, and that's because the referral pathways still sometimes don't work and the screening is not adequate. And this may be the only realistic hope that we have of providing mental health care to the 80% of the people of the country who need it and don't receive assistance. You see, my estimate is a little more pessimistic than Crick's. The challenges that we've encountered, because the system has been running a little while now, is that the attitudes, this persistence of the vertical split with mental health, which used to belong, in fact it used to be run by Pretoria and everything else was provincial, but psychiatry and forensic science, two very crucial parts of medicine, fell under state. There's a need for upskilling still primary healthcare personnel and the community health workers, so there's a lot of training and teaching to be done. Part of the problem is that everybody at every level is overloaded with patients, and what I was saying yesterday was that it's, there's a point beyond which you cannot actually carry on saying, oh, this is all we've got and this is, we're going to have to make do with the best, do the best we can with what we've got. There is a point at which the injustice of the situation needs attention, and mental health care has got an unjust share of the budget, and the Western Cape is actually dealing with essentially more people than its budget allows for, to put it in politically correct terms. I don't want to get into trouble. Another problem with mental health is that we have massively competing priorities with HIV, TB, trauma, and lifestyle diseases. Part of the problem with that is that it's taken a long time for the health department to acknowledge, which they now have, that there is no health without mental health, and that if you don't attend to the mental health aspects, all these numbers of these things are just going to go up and up and up and up and up, because most of them are behaviorally based. So that's an ongoing issue, and it's in process, and we do in fact have top management buy-in with the importance of underlying mental health. And one of the things that we've been talking about is how we need to persuade the non-mental health aspects of medicine that they need health counselors, and then latch the mental health onto that, and then start to look after these people ourselves, because they're going to need it, and I don't think the other departments are going to be able to do that. So that's one possible little sideways maneuver we could manage. We also have a problem that infrastructure is seldom appropriate for interviews with psychiatric patients or mental health clients or anybody who wants to talk about personal stuff. We still end up from time to time interviewing people in corridors, and that's hardly the most confidential of environments. It's getting better. People are taking note of the fact that we seem to need inordinate amounts of office space. We do. I mean, Tygerberg management is constantly stunned by how many offices we need for a child and adolescent psychiatry unit, but they have to explain every time. But we may need to make compromises on that as well, in terms of office sharing, not at the same time, but in sequence. Community health workers are not necessarily selected to be able to manage mental health interactions, and the supervision and the training at the moment are not always available, so that's something we need to look at carefully. Some degree of psychological mindedness must be necessary in order to do the work that we're envisaging, but we also, as Crick and Umesh have both pointed out, the people that are doing the work come from an environment where the likelihood of being traumatized, of being depressed, of being just generally afflicted by life's woes is just as great as their clients. And we have to be very careful about unconscious dynamics in terms of who's getting looked after. So that if someone spends their whole day looking after other people, there's got to be something on the inside. We've got to be looking after them so that they're not ending up functioning from a position of deprivation. And then, yeah, we've run into issues with boundaries, we've run into issues with non-judgment. Even in trained psychiatric nurses, we've run into people, in fact, being quite hostile towards particularly adolescents, who, God knows, do have the buttons, you know, they know exactly where to push, but responding to them as they would to a disobedient child, and scolding, "Skel maar dokter." And many of the adolescents that we speak to do not access healthcare because they're spoken to in disrespectful and judgmental tones by many of the staff, not just nurses. So we need to be looking at that. There's vicarious traumatization, there's evocation of own traumata. So lots of challenges, but thanks for even thinking about it. Okay.